Now, this very unusual case demonstrates the treatment of a venous ulcer that is secondary to deep reflux of the gastrocneimus and posterior tibial vein complexes. These are subfascial veins in the posterior tibial area that are aneurysmal and connect to a Cockett's perforator. In this case, we will show you how we treated this by treating both the Cockett's perforator, superficial varicosities, and the deep refluxing posterior tibial veins that were aneurysmal in size. Now, this patient has trophy blanche and a new ulcer formation. He has long-standing skin changes in the left lower leg. Denies a history of DVT, although he did have some type of procedure to the tibia many years ago, but does not know exactly what this was. The areas marked are for injection of polydilcanol 1% foam and subsequent phlebectomy. Ultrasound findings include the following. There is an aneurysmal dilatation of the medial gastrocneimus vein just before it enters the popliteal vein. There is no reflux in the SSV or GSV. Popliteal reflux is greater than 5 seconds, and there's normal flow with no reflux in the femoral vein. There is a large aneurysmal dilatations of the subfascial, actually intramuscular veins around the medial aspect of the ankle that connect directly to the posterior tibial perforator. Now, the diameter of the posterior tibial perforator is greater than 7 millimeters. It also connects to multiple visible varicosities. These large veins that you see here are actually corresponding to the region of the posterior tibial veins. They're very dilated, large subfascial varicosities. Now here, this corresponds to the posterior tibial perforator right there. You can see all these dilated vessels here. The only option we have is to clot them off. We don't know exactly the etiology of all this large dilated aneurysmal dilatations here. He's had does have popliteal insufficiency, no history of clot. You can see you have to clot these things up in order to affect healing of the ulcer. So we're going to start doing this by locally treating the areas I showed you, pulling up as much as we can of this vessel right as it exits right up here. Right there. I'm going to try to pull all that up and then inject this stuff too at the same time. Okay. Now I injected 2 cc's right here of erythema. And we'll show you in a minute the ultrasound. The foam is right under the ulcer bed. Now we're going to inject the larger veins. And this is right under the ulcer bed right here. You can see the foam right over the ulcer. So that's a nice penetration of the ulcer bed. Okay. Yeah. Now you can see there's foam in the vessels, the dilated varicosities underneath the muscle sheath, foam up in the perforator. We're going to do a little phlebectomy now of this superficial vein and try to remove as much of the superficial stuff as we can to prevent, just make it more comfortable. But you can see good penetration of this into the deeper dilated veins. Okay. Yeah. So we've mobilized all the large varicosity that was associated with this perforator. We ligated distally and proximally. You can see the vein here, proximal veins right there. So we're going to clamp the perforator and just oversew it. So we got a lot of the bulk here, a lot of the reflux superficially. So we're doing the clamping the perforator, and this will get rid of the flow from distal to proximal, as well as we actually injected those large varicosities in the submuscle sheath. Okay. Now, phlebectomy is also done in a large dilated vessel that is associated with the ulcer on the lateral aspect of the ulcer itself. This is corresponds to right over the middle meatus. There is a large varicosity. This is where we injected the foam to the ulcer bed. Now, in effect, all potential inflow to the ulcer is interrupted after foam sclerotherapy. As mentioned before, it's important to get foam sclerotherapy into the ulcer bed, since this really initiates a decrease in the cutaneous venous hypertension. This patient was scanned 4 days post-procedure. You can note the clot in the posterior tibial venous aneurysmal complex. They're non-compressible. There's no flow. This is an excellent result. The popliteal and gastrocneimus veins are free of clot and contain the reflux, which we would assume since they are quite a distance from the injection of the actual foam itself, and we do apply compression in this area while injecting foam to keep the foam localized. Now this is the appearance of the leg 4 days post-procedure. Excellent result, no swelling, no inflammatory changes in the suture sites. Now we have addressed the source of reflux by both injecting percutaneously into the ulcer bed, as well as removing all the refluxing superficial varicosities and the aneurysmal dilatation of the posterior tibial veins. If you do not address all sources of reflux locally, you may experience either non-healing of the ulcer or reoccurrence. Now, the gastrocneimus vein aneurysmal dilatation is left alone at this time since there is no persistent swelling. However, if swelling occurs, we can also do foam sclerotherapy to the gastrocneimus vein. I have done this a couple of times to decrease calf swelling, and this works very well in many patients. Although they still have popliteal reflux, it does cut down on the amount of swelling. But this is a good result. This patient should have rapid healing of this ulcer, and we would expect most of this to be closed within 2 weeks.